Yes, it's the John Cairns show, I'm afraid. I've always wanted to be a chat show host, and I could sit down and ask people to come along. I haven't had any chance to discuss with my colleague the best way of handling this, but some of my colleagues suggested two things we might want to talk about. And let me put them out here, and you can sort of boo or hiss or cheer or something. This is a conference about rising public health researchers. And while it's given some of our rising public health researchers opportunities to present, we haven't really focused on career pathways, the barriers, the facilitators. What stops some public health researchers rising? What encourages others to rise? So I think, I don't know, I haven't discussed it with my co-chair, co-facilitator, I think we could at least spend some time on this issue, because I think it's important. Can we identify things that the young researchers, young, is that the wrong? No, not word young, that's ageism. The rising, and those who've now hit the ceiling, can we identify things that are slowing you down, but also things that are working? That's the first topic I'm suggesting. The second topic is maybe, well, it's more controversial. Gender. Now, I think if I'm being politically correct, I have to say, those of you who choose to identify yourselves as female gender, those who choose to identify yourselves as male gender. Anyway, you know what I mean. Sorry, I'll just male researchers, female researchers. In many countries, there does seem to be a sort of age structure. Now, it's not, we've got some wonderful examples of women who make it to the top and beyond. I don't know if Anne stopped rising yet, but you know, she'll have to stop sometime. But if we do look around different countries in the world, in our area, broadly of public health, of health economics, these sorts of areas, you do tend to see rather more men at the top and more women at the bottom. Now, this could just be history, and back then, the circumstances were not very good for women, and so men got an advantage, and now they're getting the payback. Or is it something, have we got an enduring problem here? Is there something else happening? Might we want to discuss that? I don't know. I see one or two nods. Anyway. Yeah, so yes, thank you. I think it was actually Ian that suggested it, but that's fine. He seconded his own recommendation. But anyway, could we maybe start, if that's reasonable, with thinking about barriers to rising as a public health researcher, and also not just the negatives. What are the positive things, the things that help and have helped? Now, this is not something that those who've stopped rising are excluded from, because you can think back to what affected your progression. So who would like to bravely start? Or timorously start? But who would like to start us off? We could make it sort of Alcoholics Anonymous, you know, you could say, I was a rising public health researcher, but I stopped rising. I want to share my story with you. Yes. I don't think it's on. I don't think it's on. Oh, it is.
The first few sentences that you said, actually what I wanted to say, because I thought I was enjoying and was comfortable with my rising in research, and especially in health economics, but up to a certain level when you sort of being identified by the people surrounding you, they start giving you tasks that are actually not enabling you to focus on the area that you are interested in. Like for example, administrative tasks, head of department, deputy dean, senate members and whatnot. So this is a dilemma. When I come here, I thought, oh, this is something that I want to be. Somebody like Ann Mills, okay? But at the same time, there are a few hurdles or a few barriers that prevent me from further rising up. And actually, coming here is a good opportunity given by Prof. Kihara, whereby I can actually some sort of revisit my area of expertise. Thank you.
Thank you for that. Does that raise any other people feel any similar there? Or identify, are you rising or have you stopped rising?
Yeah, I hope so. I hope so. Thank you very much. But I'm just considering, so I'm afraid that I can make a good answer. But for Japanese, in terms of Japanese situation, as you say, there are several rising researchers, and most of them are women. It is very interesting. Women, yes, lady, and excellent ladies are involved in public health and global health research. But in Japan, unfortunately, it is unfortunately the situation for these young ladies not so good, especially for ladies who are rearing their children. The support system is not established. So I have several graduate students who are working, female students who are working and who are rearing their children. So they are always conflicted. So we have to establish to improve such system to support them. This is one viewpoint.
Thank you very much for that. Yes?
Hi, everyone. I don't want to identify myself whether I'm still rising or stop rising. But I just want to, actually this is for the researchers from low and middle income countries. So normally people who study overseas, I studied in Germany and then some people study in UK or Japan, So once they go back to their original country, what happened? Because we don't have enabling research environment or research culture. So even once I joined to University of Malaya, together with more or less the same time with the Prof. Masna, we don't have a mentor. So we don't have a very experienced, people like, Professor Mills and Johns, We wish we could have an opportunity to work with, senior people. So we are just doing, a kind of, on our own, and then, we discuss, each other. So this is one of the research culture, enabling environment, and then mentorship are lacking for the researchers in low and middle income country. Another constraint is also to get the research funding. So to get a big, research funding, you really need to have a big group, and then having, very experienced, researcher to work together. And particularly people from low and middle income country, we cannot be highly specialized. Although we love doing health economics and health financing research, we cannot survive by doing only that, area. So we have to be a kind of, generalist. We are the jack of some trades and master of some. So it's a kind of, different. In developed country, you can just, focus and super specialize on doing that research area. We have to do a lot of, research area at the same time, so maybe there's also a bit of, problematic, in your rising. Okay, that I'm sharing my experience.
Thank you. I think that's a very good observation. Thank you very much.
Yeah, thank you very much. I would be surprised, I just out of, washing hands, then I suppose I imagine that you are talking about health economics, but now you are talking about rising, what means rising researchers. So I'm responsible for the naming of the conference. So, also I sometimes get the question, what means rising? So roughly I have an image that rising is relatively younger researchers, but actually I myself feel I am rising. So there is no clear boundary. So there is always a gray area. So that's okay. But the reason why we named this conference Rising is to create an opportunity for the younger junior researchers to connect each other, to exchange each other, to then rise together. So, I have, of course, because of my age, I have a lot of experience attending the conference in Japan or international setting. So there's sometimes, a kind of a hierarchy. So very senior, junior. So in that setting, junior researchers sometimes hesitate to make silly questions, they think. So, even this conference, I expected more questions from the younger researchers, but most of the questions are almost senior researchers. So I'd like to encourage, don't hesitate to make a question. So, but for that, I thought we have to kind of destroy the, old-fashioned, structure. Sometimes, inherent in the meeting. So men and women is one, structure. The established and junior is, one structure. So if we can break such a, structure, so we can encourage more meaningful, exchange. So, this is a second, conference. So the last year we have no time just to prepare the conference. So second year we followed the same way in the last year. But I'd like to stop, at this moment, this time. So to create a very different, conference from the next year. So to make it, as I said, the junior researcher can, more actively, involved. So I'm thinking to invite, graduate students and very young researchers and postgraduate researchers. So of course inviting the senior researchers, but mainly I want to make a conference mainly organized by the younger generations so that they can establish networks, so that they can make more meaningful exchange. So if you have an idea, for the next conference, I'm very happy to accept any suggestion from you. So it's very flexible. So it's only second time. So from third time we can change it totally. So I'm very happy to get suggestion. I'm happy to use this opportunity for your suggestion. Thank you very much.
Well, thank you very much for that offer. It's very refreshing to hear that you've got this flexible approach and you're interested to get ideas. Oh, yes.
So my name is Moji from Nagasaki University School of Tropical Medicine and Global Health. And when I was grown up, so that in Asia or in Japan, there is no public health schools. And we have the School of Health Sciences in the University of Tokyo. And really, the School of Public Health was the first in Kyoto University. But nowadays, in Japan or in Asia, the many public health actually the schools are emerging. And for doing public health, actually, we need a lot of people in many variety of fields. So in my age, actually, the health economics were not so popular. And many people are from faculty of economics. But their analysis is very different from public health, so that we cannot communicate very well. It's still that it's a big problem. But in the public health, that we have a lot of the health economics and the policy and other things that we can discuss in that era of the global health. So I hope that the young generation will just become more active and become that public health that is a more wider approaches. The diversity of approaches are very important in public health, I believe. So please go ahead. So that's my message. Thank you very much.
I think we've got an interesting dependency ratio emerging as these academics, myself included, age. In order for the profession to have enough new ideas, we need each young researcher to support more old researchers. So it's a dependency ratio. I think we've got a question here in the middle.
Hi, thank you. I was actually thinking about that sort of aging population issue in thinking about public health. But I think for a lot of junior or rising or younger researchers, one of the issues that comes up is a lot of sort of job stability, especially coming straight out of your PhD or being more junior. I think where I speak to a lot of more senior faculty and staff at London School, you hear about early career sort of large grants that took them through the first 5 or even 10 years of their career, and that doesn't seem to happen so much anymore. A lot of young researchers get maybe 20% from one project and 50% from another, and they're constantly looking for their next. And I think there's a lot of sort of early career fatigue that happens. And so I think there's more people sort of leaving academia for other areas because there's more job security and more ability to have something stable earlier in your career instead of sort of building up the recognition before getting onto some of these larger, more sustained grants. And I don't know how that would be adjusted, but I think sort of the way that people progress through academia now is different than it used to be. So.
Thank you for that. Has anyone got any positives? Not that that's not positive, that's an observation, but has anyone got sort of positive suggestions? I suppose the implication of what you're saying is some way of funding younger researchers that offers a bit more stability. And your comment did echo earlier comments about perhaps you getting spread rather thinly, in that if you have to feed into various projects, or indeed if you have to take on administrative roles alongside your research roles, you're getting less opportunity to make a name for yourself and to become more skilled and better known.
Thanks very much. So, I mean, one comment I want to make really relates to all of your governments and their role in financing research in countries, because in the UK we particularly benefit from what continues to be fairly generous funding for both for health and public health research in the UK and indeed for global health research as well. And I think one of the most critical aspects of that funding for young researchers is the fellowship schemes. And I think that's really critical for funding agencies within countries to think about. So, for example, in the UK, we're fortunate in having the Wellcome Trust, but certainly if you're clinical, you have fellowships that go from PhD all the way up to whatever their highest level is called, most senior fellowships that will take you through your whole career. Or for our Medical Research Council, has a pretty good set of fellowships, especially at the more junior level. Our National Institute for Health Research similarly has fellowships that can take people from PhDs up to the most senior levels. And I think that any country wishing to develop its own researcher labour force needs to think about fellowships as a critical way of dealing with the problem you referred to of short-term funding, because it is a difficult, certainly in somewhere like the UK, and I mean, the London School is very similar to American universities, where there's a very, very high volume of research grant funding. Roughly 60-65% of our staff are on short-term contracts linked to particular research projects. And over time, people may get more stable, may bring in bigger amounts of money, but there's that very difficult period early on. And I think particularly for junior researchers, the fellowship scheme, not just the PhD, but the postdoc, several postdocs, we have early career fellowships, we have mid-career fellowships. That sequence of fellowships enables young researchers to focus on a sort of limited set of research and develop their skills on that. Just to comment on the additional responsibilities that one acquires. I mean, I think that certainly I think there's a risk that as you get more experienced, you end up with a lot of administration. But I think it's also important to have a system of evaluation within universities that rewards all aspects of an academic's performance. And in one's early years, that may primarily be research with some role in education, but one does have a contribution to make both to the life of one's own institution and to academic life more broadly. So, for example, within the school, we have 4 categories that every academic is meant to do something in, with the proportions changing as people get more senior. And those categories are research, knowledge generation, education, internal contribution, which is contribution to, it could be social life, it could be academic life within the school, and external contribution, which is your review of journal articles, contribution to funding panels, giving lectures overseas, that sort of thing, where you stand as contributing to your broader discipline. And I think what's really important is that those are balanced in the right proportions at different stages of the career. But I think it's also important to recognize that all of those areas are what makes a well-rounded academic, and that it's important to be active in all of those areas.
Thank you for that, reminding us that it sort of goes with the territory, doesn't it? Being well-rounded. And acquiring these skills. But I do see the tension that you're trying to progress your research, and your line manager or whoever is finding things for you to do that may deflect you. We haven't had much direct comment on the gender issue. Is that because there isn't one? Or it's such a big issue, the consequence is people feel unable to talk about it? Ian.
So I don't know whether I'm rising or falling, but I tell you why I feel I'm rising, is that I've got 4 children. I've got a big girl who's 26, a boy who's 22, and I've got 3-year-old twins. And they are completely delightful, and they make me feel very young. And so that's why I feel I'm rising again. But what's different from looking after my 3-year-old twins and my big children is that with my grown-up children, I was so busy, I worked such long hours, that I think, in retrospect, I really missed out on them. Whereas my twins now, I'm out the door at 5 o'clock. I don't stay at work after 5 o'clock because I've got to pick them up from creche, I take them home, and it's just, the quality of my life is so much more, is so much enriched by the contact with my children. And I think you can put it in economic terms, but working for hours and hours and hours, which is often the culture I think I've noticed in Japan, the long working day, I think you're on the real flat of the curve in terms of output, sort of diminishing marginal benefits. And I think both the system would be less discriminatory against women who have children, and less discriminatory against men as well who have children, because they would both benefit from a working day that allowed both parents to participate fully in child rearing. I think it would be a good thing for them both.
So is the message we have to persuade funders they should pay more for less, but in fact they'll be getting more by doing so. Right. We can easily talk about universal health coverage if you prefer.
John, would you like me to switch the subject and
if you've got an alternative
a
one,
challenge?
please.
So I was, so to bring the discussion back to the subject of the conference, I was reflecting on the presentations we had yesterday about universal health coverage and the current structure of systems and the reforms and the extent to which change was possible. And I suppose I was struck by the presentations of, I think it was Japan and Taiwan, and then the presentation of Malaysia. Because in Malaysia we had a strongly, well, apparently a strongly nationally controlled system, primarily with government. People should tell me later if I'm misrepresenting, but primarily government, general government tax funded, Ministry of Health, public facilities run by the government, a lot of private use, but individuals choosing to use the growing private sector, not part of the formal publicly funded health system. And in that sort of system, which is what the UK has had and still continues to have largely, it puts an awful lot of power in the hands of the government to regulate the system because it's largely publicly funded. The Ministry of Health has the power to do a lot of things in the system, including the sort of health technology assessment you talked about, John. But then we heard about Japan and we heard about Taiwan, and I think one of the points made about Japan was that the municipalities were in charge, but their ability, I think, what was it said? That they had two levers they could pull. I've forgotten now which those two were. Was it number of beds and something else? But that otherwise, I think, because the delivery is essentially through private hospitals and a largely private system, the money, sorry, maybe it was fee schedule, that was the other thing they could control. So they could control the fee schedule, but otherwise there appeared to be little control over what went on at the level within the hospitals. And I almost had the same sense for Taiwan. I think there the government has maybe the interest groups are a bit less strong. So you have had quite a lot of payment reform, for example, but still you're trying to pull levers that are quite a long way away from where the action is, because again, you're trying to influence a system that is delivered through a lot of private organizations and individuals. And I suppose I was interested by that. Well, one of the things I was interested in was why in Japan and Taiwan, given the extent of public funding, is there such limited control over what goes on in the health system and on reforming it? To make a contrast within Europe, we had the UK, which is general tax funded. We have the countries on the continent, which are largely social health insurance models with additional tax funding, but essentially a more decentralized system with a lot of private institutions. But because of the public money, those institutions are quite subject to being in the control of the national arrangements. And that degree of control that I think one does see on the continent of Europe, I mean, not as strong a control as we have in the UK, but certainly greater control, doesn't seem yet to have evolved so much, at least in this part of the world. And I don't know if that's fair, what I'm saying. I mean, John, in economics, we often, at least, I've often taught that where you have a very, very large role of public funding, whether that's compulsory insurance or general tax funding, that gives the public payer a very powerful influence over what goes on in the system. And yet, it seems in countries like Taiwan and Japan, we don't see the government being able to take advantage of the role of public funding in that same way. And I just wondered, why not? Sorry, that was a rather long ramble.
Well, I think that's a very interesting question. My first thought, of course, I'm completely ignorant about Japan and Taiwan, but I wonder if it's the mentoring of the United States. There might be a factor here. The United States has a large public spending, but very decentralized, one might say fragmented system. And is it possible at all that Japanese health policy, Taiwanese health policy has been influenced by our American cousins?
I think in the case of the UK case, all of the doctors are employed by the government, right? But in the case of Japan, most of the doctors is employed or their own business on the clinics or the hospital. And then so the bit difficult, even though some one doctor think about the public health or something, but research is done by public health people. And then the doctors have a big sort of guild or cartel. So if the public health side recommendation is against the benefit of the doctors, it doesn't work very well. And also in the political power structure, I mean, in Japan, more like, especially I don't want to blame the specific political party, but normally the ruling party was heavily supported by Japanese doctors association. So it's a bit difficult compare. In the case of the United States, more the medical fees is covered by the private insurance company. The public insurance company is somewhat very keen to lower their insurance payment, which means somewhat excessive medical intervention was regulated by the market or the profit-oriented regulation. So in the case of Japan, it's a bit difficult. In Japan, the most, according to by law, the medical organizations are not expected to make a profit, which means related to the TPP between the United States and Japan, there's medical insurance is very big problem. But although in Japan, most of the hospital are, as a regulation, as a law, are not expected to make a profit, which means they don't pay the dividend to the third party. But although they don't pay the dividend to the third party, they can retain in their somewhat the profit. I mean, if they do the excessive medical treatment or something, that's a bit of difficult. So if for the government, national public health point of view, maybe if the doctors cannot self-regulate, maybe the public health people or to the policy designer to say something. But because of the political structure and also the some so that Japanese specific problem. What I think as a clinical doctor, but I don't know much about Taiwan case, and so that might just only a personal view. It is not. Yes.
Thank you. Is there somebody who's knowledgeable about Taiwan who would like to share with us their perception?
I can talk a little bit about Taiwan. I think how the role of the government, how big the government should be, is always an issue. In the healthcare issues, I believe that the majority of physicians are consider the government is too big, and the National Health Insurance Bureau is playing a dictatorship role. Okay, so it's very similar to like the American physicians. They are like anti-government. They are anti all kind of regulation, including the payment system. But I'm trained as a public health professional, and I'm educated that the government is very important in protecting public health, especially the very precious healthcare resources. The government is important to relocate the resources, especially for the poor. And I'm working on occupational health issues, and usually workers are having very little resources, and when they have some work-related issues, they are not only facing the medical problem, but they are also facing like employment problems. So I think for many types of health services, like occupational health or infectious disease, that kind of services is not, you cannot rely on market. So we are always campaigning for expanding the role of the government. So sometimes we have some conflict. Public health people and medical people always have some, very tense relation. And I think the government in Taiwan used to be very strong up until like 1980 something. But after democratic change, the government become more rely on like a private sectors, especially the medical providers in Taiwan is dominated by private providers. So many healthcare policies are being influenced by those interest groups. But fortunately, I think there's something special in Taiwan. That is, we have very active civil society. So there are many patient groups, many labor groups, and a lot of movements, and you see many demonstrations on the street. So, and we demand the government to protect people. So I think that is something we appreciate. So nowadays, there are many groups who are interested in healthcare policies, and so the healthcare insurance policies, you can see many people join the discussion, and that is something I find very good about Taiwan.
Thank you for sharing that. Back to Japan now, yes?
Well, let me talk about two topics. One is the old topic on the environment for rising. Well, in Japan, the educational environment for young researchers have been improving. In our days, department is departmentalized and segmented, and now the Kyoto School of Public Health is a good example, a leading example. There are various departments, and we can interact within school. And also, inter-school or inter-university or trans School of Public Health activities have been rising also. For example, today we have excellent professors from Nagasaki University, for example. And, but still, the educational resources in Japan or in some other countries maybe still limited. educational resources for public health is still limited. And so we need to mobilize and resources, and also we make these kinds of resources more available for young researchers. Now we have internet or various communication technologies, and you also have e-learning system. And so the educational environment has been growing, and we need to input more opportunities for human interaction also. And so the environment and the trend for educational situation is very promising here now. And in addition, now several academic societies related to public health have been now joining to develop a new system to educate public health specialty physicians. And this kind of system will be also applied to multi-professionals also. And for example, Japanese societies of public health and other societies of health administration or environmental hygiene or occupational health and medical informatics are now jointly making a common platform to educate public health basics. And so there are, in that system, we are obliged to link with the administration, local government. And so in our case, there is one important problem, and that is the disparity between public health labor market and education market. If we get the master of public health, but the local government cannot employ that MPH people because they have their own government career path. And there are many public health positions in Japan, but many are occupied by non-public health people. And this is a big loss for Japanese public health system. And so we are now, the local government people are also recognizing this gap. And so we are now trying to link the labor market and education market through the joint collaboration of public health related academic societies and also professional bodies like public health center physicians. And also supported by Japan Medical Association and the Ministry of Health. This is one good example, one good promising example. And anyway, and I'd like to talk about the next serious topic on our healthcare system. Japanese healthcare system has been dependent on, historically dependent on private provider system. Now Japan is not very poor, but after the World War II, we don't have much. We are not very rich, and but we have to provide the system for healthcare. And at that time, Japan was reliant on private providers. And so the current Japanese healthcare system is basically based on a private provider system. And we don't, the government doesn't have enough formal power to control resource allocations in healthcare system. But the government has to reform healthcare, and so now the most influential tool for the government to control resource allocation is the fee schedule system. And this controls all kinds of financial incentives. And they also use this system to reform hospital functions into another function. They derive reform using fee schedule. But this is not enough. And so now the government proposed some council and discussion system and involving healthcare providers in the regions. But now it's just starting. And from now on, I think, as I talked yesterday, we need more visualized performance data to discuss among healthcare providers and the government. And during this process, I think more other power, like industries or citizens, will be necessary. Because, for example, to attract young physicians in rural areas is a big problem in Japan, but it cannot be solved only by the healthcare professionals. We need the support of the citizens, and we need the support of local governments, and sometimes industries, private industries, has a very good power to attract young people. And so I think we are trying to make a new scheme to manage the regional healthcare system. Thank you.
Thank you very much for that. It's very helpful to get from Taiwan, from Japan, these detailed insights.
I think just one point. I think even though the Meiji era, 19th century, there was a public health education in Japan, and also especially before the war, the Japanese government had a very strong public health policy. But the main issue or topic they define is different from these days topics. Especially these days are more like non-infectious chronic disease or something. So which means we have to redefine what the I'm not sure what the public health school have to redirect it or somewhat. I think this is there is a mutual misunderstanding between the national government, Ministry of Public Health, and also the real public health researchers. What interests? I think there is some gaps. I think.
Thank you. Sounds like it's a good PhD for someone to write about how public health was fairly prominent and then less prominent, and how it's being rediscovered, perhaps. Well, I think we're at 1 minute past 3, so I think you should all give yourselves a clap for actively participating, and we're on to the final session. Thank you.